Hello, my name is Andrea Lawrence, and I am going to attempt to do my article orally. Um, I chose a pill culture article. I believe here in America we have become we've actually been called a pill nation. My article is titled Feasibility Study of a Systematic Approach for Discontinuation of Multiple Medications in Older Adults Addressing Polypharmacy. Um, like I said, here in America, we're even called a pill nation. I believe that we are quick to give a pill and want a quick fix because that's the society we live in. If you can't sleep, there's a pill for that. If you can't wake up, there's a pill for that. If you can't pay attention, there's a pill for that. And if you don't feel good at all, there's a pill for that. Now, I'm not saying that people don't need medication, and they're very useful and helpful. I am a nurse, so I do give medications. I'm just saying that, especially with the elderly and their age, sometimes I think that the risk outweigh the benefits. And I don't know that, I know in my personal experience, it seems like the older the culture, if they're on 15 to 20 meds, it's not really looked at for discontinuation. They're just not they're not combed through for accuracy anymore. I mean, I know, like with my grandparents, like my grandmother, at one time she is 6 foot and weighs, 150 pounds, and now she's 5'8" and she weighs 125 pounds. I just don't think that, yes, they see that, yes, they take their weight, but do they really comb through their medications and say, look, these medicines are not necessary any longer? Anyway, on to my article. And like I said, I am not a public speaker, so I apologize in advance. Um, Polypharmacy is known to be a recurrent and ongoing problem for the elderly. They are less likely to reap the benefits than their younger counterparts. So my article did a study of a local community and had 70 original participants. And these ranged from folks in their own home to a local, like, senior living care. Their recommendation was to discontinue any non-life sustaining drugs, and they used the Good Palliative Geriatric Practice algorithm um, in deciding, is this, life sustaining or not. Their hope was to decrease skilled nursing facility utilization, increase independence, improve mobility, decrease hospitalization, and decrease mortality. Their assessments included of the participants, they would all be monitored. Of course, signs and symptoms follow-ups will range between 3 to 6 months depending on the disease diagnosis. Um, any kind of return of symptoms, they were started immediately. They got permission from the patients themselves. They got approval from their medical doctor or family practitioner, and family and patients as well. So, and that percentage was 100% compliance in doing the questionnaire and the follow-ups. Um, I've got my notes, so I'll be referring to those. The study went from February '02 to June '08, with the mean length of follow-up was about 18 months. So every participant spent about 18 months on this study. Um, those with advanced disease were excluded, whose life expectancy was like less than 3 months, and no cancer diagnosis were included. Just to explain the algorithm a little bit, I'm going to paraphrase it. It starts by asking if the benefits outweigh the possible adverse effects in the medication. The next one is validity of the medication and relevancy. The next one is signs and symptoms related to the drugs. And the next one is there another drug with less adverse effects than the one currently on? And if they do need to maintain a medication, can we decrease the dosage? So any kind of dosage decrease or discontinuation was done as a taper dose, and also they only stop with one medication at a time, because as you know, if you stop more than one, you don't really know if it's because of that one or the other one. So some criteria for discontinuation. Antihypertensives were a big one. If the systolic got greater than 150 or the diastolic rose above 90, then that was a stop and they would be restarted on their medication. Anyone who hadn't had reported chest pain in 6 months or greater, they discontinued their nitrates. H2 blockers and proton pump inhibitors with no active bleeding, no active complaints of GERD, and no symptoms for a year were discontinued. All benzos were attempted for decreasing and then discontinuation, and all NSAIDs were attempted for discontinuation. Again, any of the signs and symptoms, any of, because Lasix was a big one as well, any kind of increase in weight or shortness of breath, any kind of those things, they would automatically return the medication. Function was assessed, mood was assessed, and cognitive assessments were done as well. They also use the SPSS version for data analysis. Of the 75 eligible, 5 were excluded for short life expectancies. Of the 70, 18 were deemed independent, 40 were deemed frail, and 12 were deemed disabled, and that meant that they needed some sort of assistance with activities of daily living. Of the 70 sample, 62% had 3 or more disease diagnosis, 44% had 4 or more disease diagnosis, and 71% of them had geriatric syndromes. So the mean number of meds that each participant was on were 7, and that was a range from 0 to 16. 6 of them had no basis formed for discontinuation, so they didn't stop those. Out of 64 patients, there were 311 medications given for 64 patients. 256 of those were discontinued. So that's 82% of medications that were discontinued for those 64 patients. That was about 4 per patient were attempted. So now we have 64 in our sample group. 66% discontinued all drugs suggested. 25% DC'd everything but one medication, and 6 out of the 64, which was 9%, declined the suggestions of the physicians. Only 6 of the 256 drugs were restarted due to reoccurrence. That's a 2% failure rate. Like for one patient, a beta blocker, iron, Zocor, and an SSRI were kept, and on 2 patients, Lasix was kept for both of them. That is a success rate for discontinuation in 81% of participants. 84% of those were hypertensive meds. Some of those participants were on at least 4 antihypertensive medications. 48 out of 48, 5 declined, 15 didn't require any medications at all, and 11 of those only needed 1 medication. So of the medications, the most common ones discontinued were nitrates, Lasix, H2 blockers, and Prilosec, and 100% success rate in discontinuation of benzodiazepines. Aside from the small amount decline that was needed for reoccurrence, no one reported worsening of symptoms, and all included reporting an improvement in quality of life. Cognitive impairment assessments were done using the mini mental state exam. The scores actually doubled within a couple of months of this study. 10 deaths occurred during the study. The study was performed over several years, but the mean of the follow-ups, like I said, was 18 months. The mean average of the deceased was 89 years, 3 from sepsis, 1 from CHF, and 4 died at home. None were related to the study, and actually all of them reported an improvement in quality life prior to this. The results were outstanding for this article. I believe it's something that we can hope to adapt over here in America. The sample size was small. I do see that as a weakness in this study with only 64 participants, but that's a whole lot of medications discontinued for such a small sample. I know from my personal experience, like I said, with my family, my grandmother has been able to stay off of and discontinue several of her medicines, only because she has someone who speaks up for her, and she's an advocate. And what scares me for the elderly population is I know that a lot of them don't have anyone to, say, hey, can we recheck this, or can we stop this? She doesn't weigh that much anymore. Like, she takes an oral glycemic medication, and, she's lost 40 pounds over 20 years. I mean, the dose shouldn't be the same. Just instances like that. So again, I apologize. I am not a public speaker, but I thought I would attempt this. Thanks.